thank the organizing committee for asking me to talk about psoriasis, to introduce the topic of psoriasis. The technical hitch which has been there, we could not be able to start at 9 o'clock when we wanted to start. I was actually ready. I've been sitting on the desk since then. But anyhow, as it may, my name is Dr. Gakuru. I'm in private practice after having retired from the army, as Dr. Mutkuri has said. And we want to talk about, I'll introduce psoriasis. I'll talk a bit about the history of psoriasis. I will touch on the epidemiology, the burden of psoriasis, comorbidities, and I'll leave you to conclude. We have already been told that psoriasis is immune-mediated chronic inflammatory skin disease of genetic basis. That's important. And my talk today is basically because we have always been saying that psoriasis is about the skin. My talk today is that psoriasis is a generalized disease. And if you don't take anything from this talk, it is that we should take psoriasis as a generalized disease and treat our patients accordingly. Psoriasis is now listed by the WHO and the UN as non-communicable disease because of the many comorbidities it has, very severe and very severe disabilities. I'm sure if Dr. Wawero is around, he would tell us how they went around and made sure that psoriasis was recognized as NCD by the UN. We celebrate Psoriasis Day every year on 29th September. This 29th September, I'm sure we will tell you how we are going to celebrate as the Kenya Association, Psoriasis Association of Kenya, and where the chairman is again Dr. Wawero. And Dr. Wawero, for your information, is also the president of the IFPA, International Federation of Psoriasis Associations. So this is a plus to the Kenya Association of Dermatologists because we have got somebody sitting in a world body. Now, psoriasis, people started talking about it a long time ago, even before we started doing medicine the way we do it now. Galen identified the psoriasis as a health condition of the skin, and Galen lived in those years of the Anno Domini. He used the word psora, which is a Greek word meaning itch. He was a Greek person. But a British dermatologist in 1809, William, differentiated psoriasis from other skin diseases. In 1841, Ferdinand von Hebra separated psoriasis from leprosy because everything then was leprosy. Even psoriasis was leprosy. But it is not until the 1960s when psoriasis was now considered as autoimmune condition. Psoriasis arthritis was identified as a distinct condition during that time. We have had a lot of research going on the pathology of psoriasis, and this has led to targeted treatments. The biologics have been started. We'll hear about them, I'm sure, from Dr. Wawero at the end of the last century. The Genome Project in 1990s was very important because it identified several genes associated with psoriasis. And that means that we can actually now tackle psoriasis as a genetic disease. I'll talk a bit of preference. I know time is not with us. We have spent quite a bit of time on other issues. But psoriasis, we are talking about psoriasis because it is common. It's common. And it is about 2% of the world's population, people get psoriasis. In the US, the prevalence is about 4.6%, which is reported. and it has been noted to be higher in Caucasians than the Africans. At times, they used to say that there's no psoriasis in Africa, but now you can see in Africa, in Kenya particularly, we are seeing a lot of psoriasis. Males and females are equally affected, and psoriasis may occur at any age, even up to people 100 years. For the females, the mean age of the first signs of psoriasis may be 27 years, and the males may be 29 years. There are two peaks of occurrence, one between 20 and 30 years, the other one between 50 and 60 years. We see very little of psoriasis in children. I don't know pediatricians like Dr. Mukuria. I'm sure psoriasis is not the thing you see every day in the clinic. But we still see children. And these children grow with their psoriasis. It's just to say that it's a lifelong disease with remitting and relapsing and predictable. There has been reports of spontaneous remissions, and some have gone up to 5 years in remission. But this is only in about 5% of the patients. Now, why are we talking about psoriasis? And why is psoriasis so important to the world? It is because the psoriasis affects the whole body. Basically, no organ is not involved. Many organs are involved in psoriasis. So it's not only the skin, it's also psychological, and this psychological burden is the most important for our patients, because many people think that psoriasis is infectious, and so people tend to run away from them, and these people get reactive depression, and sometimes they may get suicidal ideation. Others run into alcohol to run away from their problems. So when we are tackling psoriasis, we must tackle the psychosocial burden, because these people cannot work in places, they cannot wear dresses like most of us do, and they are in a lot of psychiatric problems. The metabolic syndrome, we'll talk about it. We have talked about the psoriatic arthritis, but also there are other issues of comorbidities, which we'll talk about. Now, the comorbidities are very important in psoriasis. And if you see this diagram, there are neurologic comorbidities, endocrine comorbidities, respiratory comorbidities, renal comorbidities, gastrointestinal comorbidities, cardiovascular comorbidities. And we classify the comorbidities as classic, the emerging, related to lifestyle, related to disease treatments, and these are the ones which we call classic. The psoriatic arthritis, inflammatory bowel disease, psychological and psychiatric disorders, uveitis, and the emerging comorbidities are the metabolic syndrome we have talked about, and its components, the cardiovascular diseases, atherosclerosis, non-alcoholic fatty liver disease, lymphomas, sleep apnea, chronic obstructive pulmonary disease. The lifestyle is because these people tend to have bad habits of smoking and drinking. With the medication, you know the effects of cyclosporine, the side effects of methotrexate, and acetretin. All these things are cause comorbidities in the psoriatic patient. So we have said that psoriasis is an immune-mediated inflammatory disease, and that's how we should take it. It's not only the dermatology, the skin. No, we will have to involve our gastroenterologist colleagues, the rheumatologists, the renal physicians, and again, the cardiologists, because psoriasis is a risk factor for myocardial infarction, independent of traditional risk factors such as hypertension, obesity, diabetes, or hyperlipidemia. Meta-analyses have confirmed that the association between psoriasis, especially severe psoriasis, and cardiovascular disease. These are very important facts, and also we should think that also the psoriasis is a risk factor for chronic kidney disease. These are things we should think about because there is nearly twofold risk of chronic kidney disease. There is a over fourfold risk of dialysis, and risks are independent of diabetes, hypertension, and nephrotoxic medications. They are independent. And the risks associated with psoriasis, the risk associated with psoriasis is greater than the risk associated with either diabetes or hypertension. That is important. So we have to treat psoriasis, but does it affect the comorbidities? Yes, it does. So we should treat psoriasis carefully and effectively so that we affect the comorbidities. So how do we do it? I think from now on, you have to start screening your psoriasis patients. We'll screen for hypertension. That is, you do blood pressure at every office visit. You screen for diabetes. You do fasting blood sugar every 3 years in patients above 45 years, or earlier and more if the diabetic risk factors are present. We have to do cholesterol, maybe even more than the 5 years indicated in this chart. And we have to be more aggressive in the lipid control. Now, I've been very brief, but the final thoughts are that screening for comorbidities will improve the quality and length of patients' lives. Effective treatments make this an exciting time to treat psoriasis. And we as dermatologists, we need to ensure that effective treatments are prescribed and available to patients to prevent comorbidities. Thank you.